So in our UK real-world cohort, we have a large cohort, over 330 patients, where we've looked at the outcomes for patients in a real-world setting being treated by Glofitamab and Epcoritamab. And I think that what's been really important is seeing that patients who complete the first 2 cycles actually do very well. In a much higher risk cohort than in the pivotal studies, the CR rate is still over 30%. And if we only look at the patients who would have been trial eligible, it's better than in the pivotal studies, so 44% CR. And these responses are durable. This is in the publication, and we're going to be showing longer term durability follow-up at this EHA. I think that we've also seen that the toxicity profile is encouraging, with lower rates of CRS than reported, and showing that these can be deliverable in community hospitals. What's going to be important for us is to understand which patients aren't able to get to the start of cycle 3. And predictors of response in our multivariable analysis included LDH, performance status, prior bendamustine, and also refractory disease. Because we know that patients need to have had ideally at least 2 cycles for there to be good efficacy. And I think that understanding these predictors is going to be important. But this real-world cohort has been valuable, and I certainly think has increased the use of these important treatments throughout the UK. And interestingly, the transformed follicular cohort had a better response than the DLBCL cohort. So useful data, and I think real-world data needs to continue to be published internationally. The access to bispecific antibodies is really important for patients. We know that these are effective off-the-shelf T-cell engagers that can be started very soon after you've met the patient in clinic, and that they can be given in, I think, most hospital settings now. I think that the main thing that clinicians and healthcare providers need to be aware of is cytokine release syndrome, because cytokine release syndrome, it's a different toxicity, but it's definitely manageable, and often patients recover more quickly from CRS than they would, for example, neutropenic sepsis. So people becoming familiar with the grading system for CRS, so grade 1, a temperature alone. Often we just observe the patient, we don't do anything. We might cover for infection if we're not sure that they could have infection. But if they go on to grade 2, for example, drop their blood pressure but not requiring inotropes, or they need a little bit of oxygen but not more than 6 litres per minute, then we would treat them with tocilizumab. And it's important to treat grade 2 so that patients don't go on and develop grade 3, where they may need ITU or would need ITU support. So I think that recognition and being awareness of CRS is important, because we want to make sure that these really important treatments are available to as many patients as possible.